Sure.
What was the question? I can't remember.
Yeah, no problem.
Am I invading or am I not invading?
I think we can do it as a writer.
Can we make it so I can just keep the recommendation as it is?
I think so.
Don, look a little hacker there, right?
This is crazy. We've been debating this dental thing, I mean, up to like
12:30.
5 minutes ago.
Well, yeah.
Good, because I'd love to understand what you were gonna say.
I would love to understand it too.
I'm reading it, and I'm reading, as you say, reasonable assurance, I'm reading and saying.
Well, we figured yeah.
Did I see reasonable assurance?
No, the rule
No, I
did.
kept, I came in and I said, all right, I don't understand it.
The rule says that you have to provide on the outside reasonable assurance that they're purchased a, right? An
Oh,
exchange
yeah. I don't know
certified
what that
standalone
means.
dental.
All right, we don't have Dr. Klein yet, right?
We can talk.
Okay.
Might be on the phone.
Okay, but we have Dr. Roberts and Wayne Finch and Vicki with us, right? So we have a quorum.
And this is Larry Mathias, I'm on the phone.
Oh, are you? Thanks, Larry.
You got a friend John?
Sure.
Crowd here yet?
Well, I have 1:30, so why don't we go ahead and get the committee meeting started? And I'd like to welcome everyone to the Plan Certification and Management Advisory Committee meeting, which has been properly posted for today, February 25th. And we're video conferencing between the Public Utilities Commission here in Carson City and in Las Vegas. And we do have a call-in number. For those that have called in, please mute your phones. And please do not put us on hold, because that usually gives us some sort of elevator music or something while it's on hold. With that, I'm going to ask Mr. Hager if he'll take the roll for us, please.
Dr. Ahern? Here. Dr. Jackson?
Here,
Mr. Finch?
Here.
Mr. Mathias?
Here by phone.
Ms. Mayville?
Here.
Dr. Roberts?
Here.
Mr. Woodley?
Here.
Dr. Klein? And Chair Campbell.
Present.
We have a quorum.
Thank you very much. I don't know that we have any other announcements. Do you, Mr. Hager?
No, only with the public or the minutes. So I'll get to that.
Okay, all right. I'll open it up for public comment. Do we have any public comment in Las Vegas?
No, doesn't appear so.
Thank you. Do we have any public comment here in Carson City? Does not appear so. And do we have any public comment on the phone? All right, thank you very much. We'll move on to agenda item number 3, which is approval of the January 31st Advisory Committee meeting. Do we have any comments, amendments, suggestions? I think Mr. Hager has something.
For the record, John Hager. So yes, we posted these minutes this morning at 8:30 on our website. We just got them first thing this morning. The only thing that we have to change to it is that Dr. Jackson was not here twice. She was only here once. So we will delete one of her items there. And if
you're
there are-
right, that is why I'm tired.
That's the only comment that I have.
All right. Any other comments from committee members?
Move to accept this.
Rob Klein is here now.
Oh, okay, thank you, Dr. Klein. So we have a motion to accept the minutes by Dr. Ahern. Is there a second?
Second,
And Dr. Ash Jackson has seconded the motion. All in favor? Any opposed? Motion carries. Thank you. With that, we'll move on to agenda item number 4, which is the discussion on standalone dental and vision plans. And who is making
I'll
that
start it
presentation?
off.
Okay.
So for the record, John Hager, our Finance and Research Officer, Damon Haycock, will be giving this report. There were some final regulations.
can they hear you on the phone?
Can you hear me in Clark County?
Yes.
Okay.
There's background noise though.
Oh, yeah.
Yes, there is. It's pretty bad back here. And Mr. Matthias, can you hear me on the phone?
Yes, I can. But
Okay.
there is a background.
There's a meeting going on next door that's pretty loud. Okay, so there were regulations that were just finalized last week. I believe it was February 20th, so midweek last week. And we were going through these, not only this report, but those regulations as late this morning, trying to figure out what they meant. So bear with us as we get through this. Mr. Haycock has a majority of the report and has a pretty good handle on it, and we're going to do this as a team effort because of the late understanding of this. But I'll turn it over to Mr. Haycock.
So for the record, Damon Haycock, Finance and Research Officer for the Exchange. Good afternoon, Madam Chair and members of the committee. I'm going to be giving this report to provide information and recommendations regarding certification of standalone dental plans and standalone vision plans. At last month's plan certification meeting, we took the first shot at this process, and we went over 40 separate plan certification standards that are utilized for qualified health plans or QHPs, and their applicability to the standalone dental and standalone vision plans. At the end of that meeting, the committee requested that we separate out those items that they felt required no further discussion or review into a different section, so that way we could concentrate on those items that did require more discussion and review. And as you'll see in the report, that's exactly what was provided. Starting on page 4 and going to page 13 are all of those standards and citations that were reviewed by the committee last month and requested to be pulled out and separated so we can concentrate today on those that are pressing and that will require more committee interaction. So before I move towards the next section, which are the applied changes that may need to be reviewed, I'd like to open it up now for anyone to have any comment or discussion if anyone's had an opportunity to review those and wish to bring them back to the committee.
So again, these are the items that were informally approved, and we say informally because there was no actual vote that was taken, but there didn't seem to be any concern about these items. And as Mr. Haycock said, they go from page 4 to page 13.
So, Linda Ash Jackson, so the only issue that I had was the inclusion of essential community providers in either the dental network or the vision network. And because when we used to insure Reno Sparks Indian Colony, and when we went over there, they have optometrists and dentists and everybody, and I'm gonna make the assumption, unless you guys tell me otherwise, that those, when a health plan contracts with the essential community providers for primary care, that those essential community providers where dental and or vision may be offered should also be part of any standalone product or network. So I don't know if we clarified that from before, and so I'm asking that question today.
So for the record, John Hager, first of all, this is item number 23 on page 8, which says that a QHP issuer must have sufficient number of essential community providers that serve predominantly low-income, medically underserved individuals in a QHP service area. And I'm not sure how we defined a sufficient number for the QHPs. Could you?
So I'm there with you on the definition. It's just that when we provided coverage for this particular, just the Reno Sparks Indian Colony, we went into their building and toured all the services that were available there. And that appeared to be the place where many of the tribal services were rendered, and then only if they could not be provided there were people referred out. That's my assumption that's why I'm asking the question about, does that mean the essential community providers? Because I wouldn't want to be found faulty within a network for embedded vision for the sake of argument, that we would contract with the vendor for the broader network if we didn't have a place where, if we contracted the medical side only in that area. That's why I'm asking the question. You know, shouldn't that be part of the network? If it's not, does it meet the does it still meet the standard?
I'm sorry, so is your question, does the tribal clinic meet the
So what
requirement?
I'm saying is, if we, I thought tribal clinics are defined also as essential community providers, right?
Sure.
So what I'm saying is, I'm asking the question, with regard to dental and vision, what is the full scope of services that are provided in that particular clinic or other clinics of its kind necessary to be contracted to meet the letter of the Affordable Care Act? I'm asking a
Good
question.
question.
Because I told our vision vendor this morning that she needed to go get them. So that's the question I'm asking, because,
Can I take a shot of that?
okay,
Can I think that I would agree with you that those tribal services would be defined as essential community providers. But I think under this act, you don't necessarily have to contract with them so long as you can show that you have sufficient essential community providers to take care of the low-income members in your plan.
That was Dr. Roberts, isn't it?
right.
Yes.
Okay, thank you.
For the record, John Hager, so I believe what Dr. Roberts said is generally correct. The act doesn't require that a carrier contract with any specific essential community provider, but that they attempt to contract with them. They have a sufficient number. We have not defined sufficient number. So it's pretty flexible. I don't know if we intend to define what a sufficient number is. And it may depend on the service area.
Right, and that's my point. So that's my point. So if there's, for the sake of argument, a dentist out in Nixon, at one of the tribal clinics that comes out there every other week, for the sake of argument, is it reasonable to assume that people would come in from Nixon? I don't know what the answer is. I just want to be able to be compliant. So I know you were talking about not doing network adequacy within the realm of the standalone plans just as yet. But I'm just asking the question so that, because, you know, we're on a timeline to be able to deliver a network and a plan right now.
So I think the concern is that we need to balance the needs of the consumers with the cost. We don't want cost to be too high. We
Right.
should not require that the carriers be held hostage to a specific provider that's the only provider in the area. On the other hand, we want to make sure that people can access services. And so the, I don't know, negotiations or the contract rates or the process needs to be reasonable. I don't know, I mean, I realize that I'm being vague on that because it's difficult to say what a reasonable rate should be for a dentist out in Nixon, Nevada. And
By the gentleman from Delta Dental's here, maybe he can help.
I-
Okay.
or perhaps one of the doctors in Southern Nevada, or one of the other members have a comment or concern about it. I don't know how to define it. I don't know if we want to box ourselves into a specific definition.
I'm not saying you should, I just need to understand, you know, from the carrier perspective, if that's gonna be part of the judging criteria, you know, then what parameters are there? You know, so, or you say, okay, we're only looking at, a sufficient number of essential community providers, you know, and so sufficient number for primary care may be completely different from, you know, the ancillary services.
I would agree that it should depend on the kind of service that is provided.
Dr. Ayer?
Perhaps some of the societies might have a definition of the, maybe not the ideal, but one provider per number of population. Is that where you're going with this?
Well, what I'm saying, I mean, there are Medicare criteria
Yeah.
for other providers,
Right.
but I don't know if there's
From the-
criteria for dentals.
To the dental associations perhaps have a definition of what they might consider sufficient, acknowledging that they may be a vested interest in this also. Looking to the back.
Do our dental offerers have a comment? Could you come on up over here?
Yeah, I don't know whether I can answer it or not, I'll try.
You want to identify yourself for the
Yeah,
record?
Dr. Robert Talley, Executive Director, Nevada Dental Association. What goes on out in the tribes, we're not sure. We know we have dental services being rendered in the tribes. So I think the good thing about standalone plans is they allow people to have, they're all going to be covered. They're going to allow them then to go to any provider they want, which would be the providers in the tribes. The tribes providers now, I do believe, take Medicaid, they take CHIP, and those kinds of plans, and these are going to be the same kind of plans. So as far as ratios go, what's good? A good ratio, dentist per population ratio, it's all over the board. Probably in our state, 1 to 2,500 is a pretty good number. So I don't know if that answers it or not. I know, are you familiar with the tribal units? I mean, I know that there's a certain number of medical facilities in the tribes, and a certain number of those, I want to say, don't hold me to it, I'm thinking there's 12 medical facilities amongst the 20 or so tribes.
I don't know, I'm
Yeah.
not familiar with all of them. I know that because we have sold insurance to many of them,
Yeah,
we have made accommodations for the members to receive services at each of the clinics that
Right.
we've insured the population. But we have not done that in the past for dental or vision.
okay.
Right, so, and that was a problem for at least one of
Yeah.
them. So now that there's a mandate, I'm just asking the definition of the
Yeah.
mandate so we can be compliant.
The last information I have was, and this is just from working with the tribes themselves, to try to get, UNLV Dental School wanted to try to put some of their students into some of those tribal clinics to give the kids an experience out there. And from that information, there was 12 medical facilities. 7 of the 12 had dental facilities. So, you know, I know there's something going on out there. How big they are, how many dentists they have, I can't answer it.
I think we need to
Take it back and figure it out.
figure that one out.
Okay.
The concern, of course, is if we set a specific number or a specific ratio, it may be impossible to form a network to do that. On the other hand, if we don't, it could be that people are not served. It may make sense, and we'll have to go back and look at this in greater detail, that we let the market do what it needs to for the first year or so and figure out what is working and what isn't, because we haven't done this before. And when I say we, I mean all of us have not done an experiment like the exchanges before. So it might mean that we have to wait a year or two before we understand it better.
But you're not gonna I mean, I think what I'm looking for is the assurance that you wouldn't decertify a health plan purely on the fact that they didn't have the essential community providers for the standalone dental or the embedded pediatric patient.
it is not our intent to be a rule miser and disincentivize carriers to participate in the exchange. We want as much participation as
Okay.
possible. Again, we need to make sure our consumers are protected, and if there is something that we feel is glaring, we will work with the carriers to come up with a plan to make them compliant.
Okay.
But I don't think that we would decertify. I think that we would probably be a little more lenient in the first year, and as we worked through this and we found issues, we would work with them to make sure that we could come up with a game plan, a timeline to get them where we think might be necessary.
Okay.
And I
Great,
think
thank you.
also this touches on the broader issue of sufficient providers. I mean, this
Right,
is a
the
national
network-
issue.
Right,
And I think, you know, I agree with John that boxing this in, knowing that you're already going down the path of insufficient providers is not a wise thing to do.
not disagreeing,
Yeah.
just trying to clarify.
Yeah. And that, quite frankly, is why we were trying to get the dental students in. And then come to find out that we found out that there was quite a few dentists in those tribal clinics already, to the point where the tribes didn't really, you know, it's kind of hard dealing with them sometimes. They really didn't want to address that yet. So, I don't know.
Well, let's put 23 needs to be developed a little bit more. And it may be that staff comes back with a question, we can't develop it any more than that because we don't have enough information
Okay.
yet.
And probably we need to develop this with the network adequacy lens. We need to come back next month and talk about network adequacy some more. So we'll include the sufficient number of essential community providers for all aspects of coverage, whether it's health, dental, vision, to make sure that we have a better understanding of that.
All right, so Damon, do you wanna, are there any other questions on the, what was it, page 4 through 13? Anything in those tables? If not, we'll move on to the ones that we wanted to discuss a little bit further. And I believe, Mr. Haycock, that starts on page 14.
Yes, yes it does. For the record, Damon Haycock. One thing I want to bring to everyone's attention is you'll see how these numbers look like they start to go out of order. What we did was we numbered them in the order in which they were presented last time. And so we took those out that needed to be reviewed again and for the committee discussion, and left them with the same number that they were entered, so you can follow it if you actually have the last report or someone else has the last report and wants to see exactly what happened to that specific standard and citation. So there were some applied changes that may need to be reviewed. These were changed pursuant to the January 31st plan certification meeting, and the plan certification committee meeting. We recommend that they be reviewed and approved. First, it starts with number 12, that QHP issuer must offer a child-only plan at the same metal tier as any QHPs offered to cover an adult population. And this report clarifies that standalone vision is only for adults, as medical QHPs are required to include pediatric vision coverage as part of the 10 essential health benefits. So therefore, standalone adult vision plan is not required to include a child-only plan. And you'll see where we struck that in red on that report and replaced it with no. And number 27 for enrollment periods. In the original report on January 31st, there was discussion that we needed to include special enrollment periods. That was a clerical oversight. The regulation already requires issuers to make special enrollment periods available. It did not include the language on that first report, so it is updated to include that requirement. That is on page 14, and those are the only ones that changes were proposed that were made. And I open it up if anyone has any comment or questions about those citations and standards.
Any questions from Las Vegas?
Sorry, Ron Klein for the record. Can you repeat what goes on with pediatric dental again? I'm sorry, I missed that.
Vision.
Isn't there vision and dental?
Again, Damon Haycock for the record. If I understand what you're asking, there was 2 changes that were placed on 2 separate citations for the pediatric dental and and adult vision. we failed to put in specific language for special enrollment periods that we've included now that are applicable to this standard and citation. On the other one, in regards to, do you have to offer a child only? Because the 10 essential health benefits include a child only vision requirement. We changed that from the standalone vision certification for the adults. If you provide a standalone vision adult plan, you do not have to provide a standalone vision child only plan.
So, for the record, John Hager, just to clarify, so if you recall in the previous version of this report, we had standalone dental and standalone vision. Instead of 3 columns, we had 2 columns because we had combined the pediatric dental and adult dental, but they are in fact 2 different things. There is a specific exception in the Affordable Care Act to allow plans to not offer pediatric dental if there is a standalone pediatric dental plan. So you've got that first column there, and any plan that is covered in the Affordable Care Act is required to have a child-only plan. This would be specifically that it is this is a child-only plan. However, in discussions about the adult dental side, the limitations of qualified health plans do not necessarily apply to adult dental. A perfect example of that is currently there are max benefits for dental plans. That can apply to an adult dental plan, but it cannot apply to a pediatric dental plan. A pediatric dental plan can only have an out-of-pocket maximum where the individual's liability is limited to a certain dollar amount. But in typical dental plans today, if the plan has paid out a certain amount of money, then you would end up paying everything that's remaining, and there's no limit to the liability of the patient. And so, in order to minimize the disruption to the market, we've separated out the adult dental. Because it's adult separate from pediatrics, the adult dental plan would not have a child-only plan. The pediatric dental, of course, would be child-only. On the vision side, there is no exception in the Affordable Care Act to split out the pediatric vision. Therefore, all qualified health plans have to offer pediatric vision coverage. So therefore, any kind of standalone vision plan that we are talking about is, by definition, adult only. So therefore, it cannot be a child-only plan for the adult vision standalone plan.
What if I thought the conversation last month was that if a person doesn't purchase their health insurance through the exchange, then their plan doesn't have to meet the requirements of the ACA, correct me if I'm wrong, and then, so there would be a purpose for having a standalone vision plan in the exchange, so that somebody could have a health plan outside the exchange that didn't have pediatric or adult vision and still go into the exchange and get that plan that way. Am I remembering that correctly?
Yes, we discussed that. I don't know what the final decision was.
I think there wasn't one, which is why we're here today. So I guess my point is that I'm getting confused here. Hopefully I'm not the only one. If we don't choose not to have a standalone vision plan for pediatrics because we say it's part of the QHP, then a person who doesn't buy their insurance through the exchange will not be able to go into the exchange and buy a pediatric vision plan. So I'm arguing, I think I'm arguing against the report and saying that we should offer standalone vision plans because there are people who will not buy their insurance through the exchange who still may want to go into the exchange and receive supplementary coverages.
It's a supplemental product.
For the record, John Hager, so there's a couple of issues. So first of all, the entire individual and small group market is required to include all essential health benefits. So
Even if you're
outside now, unless it's grandfathered or a large group plan. So grandfathered or large group plans theoretically could not include the pediatric dental or vision plans, but on the other hand, they could not include a lot of other products or essential health benefits. So that could allow them to purchase coverage on the exchange. The concern that I have, and I don't know if it's operationally, fiscally, or exactly what, but we have designed our pricing mechanisms to reflect that everybody's going to purchase a qualified health plan, there is a fee that we've designed, and there are smaller fees for the supplemental products. Those smaller fees for the supplemental products are based on the fact that you are purchasing the plan, the QHP on the exchange, and I think Dr. Klein, we had a discussion about this afterwards. If we have a person who purchases, say, a standalone dental plan only, the 36 cents or the whatever is that what it was, 36 cents, would not cover the cost of all of the administrative functions of the exchange, getting the mailings out, the billings, the collections, etc. Now we could create a complicated scenario where that's only if you charge a higher amount if it's or charge them the base QHP rate. If you haven't selected a QHP, I don't know exactly how that would work. It becomes very complicated and operationally more difficult to do that, and I would hesitate to put that additional IT burden on our vendors at this point.
So, Linda Ash Jackson, so we spent an hour this morning talking about this, and I have an understanding that for the small group adults and individual adults, it's perfectly reasonable for health plans to sponsor or co-market with a vision plan that would have an adult vision or an adult dental benefit that could be more designed to the current benefits, which is a maximum benefit per year, right? In dollars, and some in prevention. And so I think that that's going to be available as we sell, because some customers are going to say, it's great that my kid is covered, but I want X. So there will be pricing available, I'm sure, in the marketplace for multiple dental and vision vendors to have that. And on the large group side, I understood that we could still have a combined pediatric and adult plan with a maximum dollar benefit for a while. We wouldn't have to meet that essential health benefit plans.
Yes, for the record, John Hager, so I think,
And I'm sure that other carriers will offer that as well.
yes, my understanding is that many of the standalone products that would be offered on the exchange would also be offered off the exchange. And so a person would not have to come to the exchange to get it.
Right.
My concern, of course, is that based on our current structure, we would lose money off of the individuals that came to get supplemental products only. We could easily refer them to other places to purchase that coverage.
It's really up to you whether or not you want to bring people in or not, who may not qualify.
Yeah.
But you are going to have the situation, unfortunately, you might have to deal with, where they no longer qualify for the subsidy, or they get a job and go into a large group insurance and they want to keep something you've already sold them, the standalone dental. So you guys are going to have to figure out what you want to do.
And certainly an individual who purchases coverage from us, say they lose their advanced premium tax credit, or for some reason maybe they get employment and they're no longer covered under the medical side, they would terminate our coverage. They could still pursue coverage with the organization itself. It doesn't have to be through the exchange. I think our leaning is to make it simpler rather than more complicated, at least for initially, till we get some experience under our belt. But certainly, if the board desires to provide coverage to standalone for the standalone products only, then we will do what we need to make sure it works.
I think you'd have to have something in the system that has a minimum fee structure, so that if you're only buying something that's 36 cents, then our minimum fee pops in so that it covers the cost of doing business.
Definitely, and then the difficulty becomes, now you're dealing with a product that is about 10% the cost of a dental product, for instance, is 10% the cost of a medical product, and so or I think it was actually 7% based on 2011 data. So now you're charging a fee that's much higher, and they have to figure out how to absorb it. The dental plans, the standalone dental plans have to figure out how to absorb it, and that becomes complicated as well. I don't know what the right answer is.
They'll have to have two separate plan structures offering the same benefits. One, if you're being charged higher by the exchange per member per month to offset to the clients, or one where you're only being charged 36 cents per member per month, or some hybrid to pick up and project what you're expecting to get in those people that are only getting supplemental products.
Are you allowed enough flexibility within the scope of the exchange rules to be able to say, you've got to buy everything or nothing?
I think we are.
So
I
then
think we are, and
then that's a decision you have to make.
and I think the one issue we still have to figure out is that our statute does not yet allow us to offer standalone products. We're working through that piece.
I saw
We're
that.
assuming
When-
that that's gonna
when-
happen for
when-
us.
I saw that. When do you expect that that's gonna pass? Because
June 3rd.
our plans, our plans and underwriting are due prior to the finalization of that potential law.
Yes, so, well, I believe they're due June 7th, and the
I don't think the division's gonna be happy if they get
I
it all.
agree
on June
completely.
7th.
No, I agree completely. So they would like to have them as soon as possible so they can get their work
That's
going.
affirmative?
Yes. I mean, the answer I can give you is June 3rd, of course.
Okay.
I would like to see it earlier. Now, on the dental side, we can do the dental based on our authorities. Our statute gives us the authority to comply with the Affordable Care Act, and the Affordable Care Act says that we shall offer separated dental products. So we have that authority, even though the statute doesn't quite jive with that. The issue, of course, is on the vision side, where there is nothing in the Affordable Care Act to allow for standalone vision products. But again, I do think that I don't foresee any significant barriers to doing that. There are some concerns, some brokers are concerned about the way that we've put our language in the statute or the bill, but we can work through that. I just don't know when that's gonna happen. If I were a betting person, I would say that the standalone vision and dental plans will go forward. Whether or not the language in the bill is as flexible as it is currently, or it becomes more specific, I think that we will be allowed to offer standalone dental and vision.
Okay.
Not that I would ever assume what the legislature is doing.
Dr. Klein?
So, John, you were mentioning that there are pricing issues with standalone vision and trying to figure that out. So what are you proposing for standalone dental, since the issues should be similar between standalone vision and standalone dental?
The issue is the same for both dental and vision. Right now, the fee for a standalone dental plan is 36 cents per member per month, and I'm fairly confident that that will not cover our costs for mailing, collections, etc. And so I'm concerned about doing that. To fix that, of course, you would charge a minimum rate, but then you run into the difficulties where there's two separate rates that the carrier has to figure into their rates, and I mean, it's the same issue that they're going to have with on the exchange, off the exchange issues. So I'm not sure how they deal with that, but it becomes administratively more complex dealing with those billings. I think my recommendation to the board would be that if somebody wishes to purchase standalone dental or vision products without purchasing a qualified health plan, that we would refer them to one of our carriers in their service area and let them contract directly with the carrier.
You give them a list of everybody.
We give them a list of everybody and say, here you go. Now, they should be able to go onto our web portal and shop anonymously, and they could potentially pick a plan on exchange and then go to the carrier directly, but I think that might be the best answer, at least for the first year or two.
All right, so do we have any other questions then on what was item number 12 and 27 on page 14?
I have a question. I'm just thinking through this whole thing. What's wrong with, it just seems so complicated and expensive to offer these dental and vision plans if you don't have to. How about not doing it for the first couple of years? I mean, making the qualified health plans include what they have to include and not go down that road. People can buy it on their own.
For the record, John Hager, so we have to offer the standalone pediatric dental plan. That's required by the Affordable Care Act. And that's the most complicated piece of the whole thing. So if we're going to figure that one out, we can certainly figure out the adult dental and adult vision. The other side of that is if you are an adult purchasing a qualified health plan on the exchange, that you just might want to have dental and vision products as well. And as long as you're already purchasing the QHP, operational administratively, it works out. So I think the adult dental and adult vision side is simpler than the pediatric dental side that's required. Does that answer your question, I hope?
I'm not sure it's simpler, but.
Yeah. Now I'm back to being confused. So we are required to offer pediatric dental according to ACA as a standalone plan, correct?
Correct.
John? Okay. So are we going to then offer an adult dental standalone? And is that what you're also saying then? Because you're saying people might want to go there and purchase it?
I am saying that an adult who purchases a QHP on the exchange does not have the ability under the essential health benefits to get dental and vision coverage, because dental and vision is specifically pediatric dental and vision, and that as long as they are shopping for medical coverage on the exchange, it would be appropriate for us to provide a dental and vision product for those people who purchase a QHP on the exchange.
So now we're talking 3 out of 4 possibilities, if I understand correctly. So now we're going to offer pediatric dental, adult dental, and pediatric vision?
Adult vision.
Adult vision. So the 4 permutations, the only one you've left out is pediatric vision.
That has to be embedded into the regular plan.
But we talked about the fact that there would be circumstances under which they might not be present, because if you're a large group employer or a grandfather plan or any one of those things. And the argument against putting pediatric vision as a standalone plan was there was a lot of complexity associated with doing that. But it seems like the complexity that you were concerned about, you're going to do for 3 other permutations. So why not just do it for the 4th and be done with it?
No, the complexity is offering a standalone dental or vision plan, whether it's adult or pediatric, offering that without requiring first purchase of a medical QHP. The exchange has been designed around purchasing a medical qualified health plan, and the additional offerings are supplemental to that qualified health plan.
All right. So basically the 3 of the 4 permutations you're talking about are only if you only get to purchase those supplemental plans, only if you're purchasing a QHP in the exchange.
Correct.
Okay. Seeing a little light here.
All right, let's move on to page 15 then, which would be item number 5 under the old table.
Yes, for the record, Damon Haycock, these next few standards and citations were requested by the committee for further review. in greater detail. And so we'll start with the one where QHP issuers must offer QHPs which comply with the cost-sharing limitations on deductibles and out-of-pocket maximums. It is number 5 on page 15. And initially, we discussed that it must have a reasonable annual limitation on cost sharing as determined by the exchange. So the requirement that a dental EHB demonstrate that it has, again, that term reasonable annual limitation on cost sharing was never defined. The limitation is left to the discretion of the exchange. However, in the February 20th final rule that was released last week, it is clarified that the exchange determines what constitutes a reasonable out-of-pocket maximum for a standalone dental plan. So it's for the out-of-pocket maximum parameter. We had, if you continue to read through the report there on page 15, because CMS had not defined reasonable in their final rules, we had recommended in this report to the committee develop those parameters such as annual out-of-pocket maximums and premiums. But this rule, again, as we did discover, or excuse me, not premiums, but deductibles. So there's a typo there. But that has been clarified in the final rule that was released in February 20th, that it's a reasonable out-of-pocket maximum. And so that is something that needs to be determined by the exchange and that we bring today to this committee.
So, for the record, John Hager, there's a couple ways to look at it. Either the committee and the board could set a maximum out-of-pocket for standalone pediatric dental plans, or they could let the market determine that over the next couple of years. The maximum out-of-pocket cannot be any more than $6,250. At least that's the 2013 number. It might be adjusted up a little bit 2014.
Well, can I just clarify that? Because the 6250 I thought was specifically referable to the medical plan. So is it reasonable to say that that's the number, then the person could have basically $12,500 out of pocket? I mean, I'm just being devil's advocate right now, or is it instead of our sitting here saying this is reasonable, is it better to go to your consultant or actuaries and say, here's what we need to figure out, here's what the plan provides based on income levels or whatever, wherever you are, based on what it is, what's a good number? How much does this all cost?
For the record, John Hager, so I wasn't trying to imply that 6250 is reasonable.
Okay.
I was simply stating that legally it
You're
cannot
so
be.
patient with me.
That's all right. that legally it cannot be any more than 6250. That the cost sharing limits that are defined in the Public Health Services Act apply in the same manner to the standalone dental products.
Okay.
So legally it cannot be any more than 6250. And we certainly can go back to our actuaries to try and figure something out, whatever that something is. One of the conundrums that we have is transferring the current market conditions into the 2014 condition. And as we stated before, there are currently max benefits. So that, let's say you have a $100 deductible, the max benefit is $1,000. If it's a 20% coinsurance, I believe that's $5,000 in expenses.
And then there's usually a 50% coinsurance on major stuff.
50% coinsurance on major things, perhaps root canals, what have you. So maybe you're only looking at $2,000 total benefit. Or it's $1,000 max benefit or a $1,500 max benefit. The total covered services would be $2,000 or $3,000, and then the individual is liable for the 100% of everything after that.
Exactly.
So going to the future where there's an out-of-pocket maximum but not a max benefit, now you shift the liability to the plans. I'm not saying that this is a bad thing, but we are concerned about premium cost. And so there is no max liability to the plans, and therefore the premiums theoretically will go up for standalone dental. And I don't know if that's the case or not, and it'll depend on how the deductibles and coinsurance and everything is moved around. so we could either bring this back with more data from the actuaries. We could allow the market to set that amount, and and the markets will set the max out of pocket. If we don't set a limit, or even if we do set a limit, the markets could set a lower out of pocket maximum depending on how they want to market that. Depending on how the carriers want to market that to the public. But we're basically looking at deductibles, co-insurance, co-pays, and out-of-pocket maximums. And with the, 70%, 85% actuarial values, I'm not sure how much room there is to move those around. I leave that to your expertise.
Dr. Roberts, for the record. I think it's really difficult to try and discuss what the out-of-pocket maximum might be for a particular pediatric standalone plan when we haven't even talked about what the benefits might be within the plan. And I'm sure that all the pediatric or the dental plans are thinking about that. And how are they going to limit the benefits? Just because there's no maximum or no maximum benefit doesn't mean that you can't limit the benefits. For example, you could say that we're only going to offer stainless steel crowns instead of porcelain crowns. Or we're going to limit they have to have so many, it carries on so many surfaces before we'll cover a crown. Or we're only replace a bridge or something every so often. There are ways to limit utilization, and those utilization limits are actuarially tied to what the risk to that plan is, and therefore that would help them determine what their out-of-pocket maximum might be in order to cover what they think is going to be the entire benefit per person per year.
Well, you have to
And
chip.
I think it
you
would
have
be
to chip
better
that.
served to let the dental guys figure that out and see what happens for a year or two and then settle on something.
Dr. Roberts, I didn't hear you because of the cough. Did you say that let the carriers figure that out over the first couple of years?
Yes.
So, and to the first half of that discussion, Dr. Roberts, you're absolutely correct. The limitations on services, it's difficult it's difficult to have that discussion here without a better handle on what those services are. Of course, those services are defined in the Essential Health Benefits Package, which I believe it was the CHIP dental. So those services are defined. But of course, we have not necessarily looked at them I guess we sort of looked at them with this committee back in October. But yes, you're absolutely correct. It's going to be difficult to really understand how those impact. So it's up to the committee to determine whether or not they want to review this in more depth, or if they want to let the market decide where it goes the first couple of years. If we decide to do an actuarial report, typically those studies cost about $50,000, and we would get on it obviously as quickly as we can, but we are running out of time.
So, is the Division of Insurance, when they review the plans to come up to verify whether or not they're close to the recommended essential health benefit, going to have a calculator to use for the standalone dental plans?
It's not going to be. Okay.
Sorry, Glenn.
Sure.
You can sit long.
Hi, Glenn Shippey for the record. So as we found out, the federal AV calculator, we've known it for quite a bit of time, can't handle standalone dental. So the final rule instructs standalone dental to not use the federal AV calculator. So it's going to have to be actuarially justified, and that burden will be on us to review the data and how that data is used and assumptions around the data. We do have our own internal resources. I won't tell you what they are, but we have acquired some technology that we can use as an alternative AV calculator, if you will. So we're getting ready for that. Dave.
So Glenn, can I ask you a question? So Steve Woodley for the record. So if I understand you correctly, the floor for the carriers would be to simply match what the CHIP dental plan provides. Whether it's dental, dental and basic, basic and major, whatever the levels of services are defined in CHIP, that would be the floor that you would use as a litmus test to find out if in fact we are compliant. And anything above that would be just above it. Would that be a fair statement?
Yes, that'd be a fair statement, but the cost sharing around that, again, where those standalone dental plans have to be, there's the low and high option, 75, 85. So the
70, 80.
Oh, 70, 85, that's right. It was 75 down to 70 in the final rule. So how will we determine as a regulatory agency compliance with the 70 or 85? So what data are we going to reference? How are we going to, what tools are we going to reference? And that's something we are working on internally. But so there's the minimum essential health benefits in CHIP, and then there's a cost sharing structure that gets us to the MLR requirements.
So you're comfortable that if in fact the decision was made for the carriers to sort it out for the standalone products, that you would have enough information and the tools to be able to say whether or not the plan, the standalone dental plan for pediatrics met the letter of the law in terms of an expectation of reasonable?
And there will be variability in the marketplace. There won't be the same right answer for every carrier, every plan. There will be differences. There will be differences in the data that they're going to submit and the assumptions that they're going to use. But we will establish internally a reasonable range. And if the proposal falls outside that reasonable range, then we'll go back to the carrier with some additional requests.
Well, and I think listening to John and knowing the time frame that we've got, I'm not sure we have enough time to put a proper analysis together to say what those out-of-pocket maximums should be.
No, I agree, but I think the key here is to show that to rely upon the division who has a documented process to be able to provide that. If that's a reasonable approach to take, then that's a motion that I would make, because not because the time frame, but because they've experienced it and they'll be managing it on an active basis. You can always go back and look at it again, right? So it's not as though, and it's a reasonable approach, and it's similar to how the evaluation of the EHBs are going to proceed on the medical side, so there's a parallel consistency around that.
And again, to be clear, we don't intend to say, these are the rules, if you don't follow them, you're out. These are the rules, and if you don't meet them, we're going to work with you to get to that point where you do meet them. And so it'll be a back and forth process throughout the spring. If there's something that the DOI sees or that we see that needs to be fixed, we'll work with you to get them fixed.
And John, I have one additional question. Steve Woodley for the record. Do we know, or does the law require that if Delta Dental is going to be the primary vendor on the exchange to take care of the pediatric standalone dental product, and the law cites a high and a low plan by actuarial value, are they required to offer both a high and a low, or can Delta simply say, I want to offer the high only?
For the record, John Hager, we don't think that there's a requirement to offer both. We think, and I think that's going to be discussed
Next.
later.
Okay, sorry. All right, never mind.
I think it's like a great segue to the next one.
Okay.
So, all right, so are you ready for a motion?
Yes.
Okay. I move that for the standalone dental product, that the definition of the patient and member cost share for the maximum out-of-pocket deductibles, et cetera, as defined in the Affordable Care Act be delegated to the Division of Insurance's process by the exchange, or you want to phrase it differently?
Can I add a friendly amendment to that?
Sure.
Ron Klein, could we just say, Division of Insurance and Executive Director of the Health Insurance Exchange Board?
I'm fine with that. Are you okay?
John was complaining he didn't have enough work to do, so I want
All right, so we have a motion and a second on the floor. Any further discussion? All right, I'll call for the vote. All in favor?
Aye.
Aye.
Any opposed? Thank you. You know what, that does remind me, on the prior page, we had 2 amendments on that. Do we want to just do a motion to accept both of those two?
Move to accept the amendments to the documentation on the prior, on page 14.
Okay, is there a second?
Second.
Okay. All in favor of the motion?
Aye.
Any opposed? Motion carries.
None.
Okay, let's move on to page 16 then.
Damon Haycock for the record. Like Mr. Woodley had said, we're going to address this issue next on offering a high and low actuarial value. The rule finalized on February 20th state that we could not see a requirement that dental plans must be offered at both high and low. And so we don't believe there is a requirement to offer plans at both actuarial values. The original report where we took this from showed that low actuarial value of 75% and the high 85%, but as was alluded to repeatedly today, that has been reduced to 70% for the low and remains at 85% for the high actuarial value. So we see that, for instance, a dental carrier may decide to offer only a high actuarial value plan or, again, only a low. That applies to both numbers 6 and number 11 on page 16.
What about number 26?
On number 26, that an issuer must charge the same premium rate without regard to whether the plan is offered through an exchange, an agent, or direct, and it may vary by rating areas set forth in the Public Health Services Act. While the rate must be the same for a qualified health plan offered both inside and outside the exchange, it is not required that that qualified health plan be offered outside the exchange for standalone products.
And just to clarify that, it is not required, a QHP or a standalone product is not required to be offered outside the exchange. I think we might have said otherwise in previous meetings, that if you offer a QHP both inside and outside the exchange, the rate must be the same. However, you are not required to offer that QHP outside of the exchange. It can be offered only inside the exchange.
All right. Do we have any further discussion on any of those? And if not, do we want a motion reflecting the change in the percentage for the low end of the dental plan?
I make a motion that, Steve Woodley for the record, that we accept the elements contained on page 16 reflecting the new actuarial value rates for the low and the high to be 70 and 85, and also to validate and agree that the carriers, the dental carriers, are not required to offer both. They can offer both, or a low one or a high one, or what have you.
Do we have a second to that motion?
I'll second the motion.
Thank you, Dr. All right, I'll call for the vote then. All those in favor of the motion?
All right.
Aye.
Any opposed? All right, moving on to page 17.
And Damon Haycock for the record. This deals with the accreditation for standalone plans. Initially, we looked at doing credentialing should be required. However, further research, institutional accreditation does not exist for dental and vision plans that we could find. However, the NRS that covers accreditation describes the process by which carriers can obtain information related to the credentials of healthcare providers. Staff recommends not requiring any type of accreditation for plan year 2014 for standalone dental and vision plans, as this information is not readily accessible. And as you've heard throughout today's meeting, that time is of the essence. Staff will return to the board with a recommendation regarding each of the 9 items listed in the description, and that's in that description section for number 32 there on page 17. Clinical quality measures, patient experience ratings, consumer access, utilization management, quality assurance, provider credentialing, complaints and appeals, network adequacy and access, and patient information programs. So those 9 items listed there, staff will return to the board with a recommendation for plan year 2015.
For the record, John Haggard, in some of our discussions with other states, nearly every other state is wrestling with all of these same issues at this point. When we try to do our research, it's very difficult to find any other information on any of these items for all of the standalone dental items, because they're all getting to it here. The medical QHPs have been the elephant in the room, and we've been dealing with those issues, and we said, okay, well, nationwide, we'll deal with dental when we get to it. And suddenly it's this big issue that's very difficult to handle. And I don't think anybody was really fully prepared for how complicated this would be. So we're all kind of in the same place where we need to look at these things. We all agree that we need to look at these things, but we're not sure exactly how to look at them for dental.
So I would have a few suggestions for you, not necessarily to look at it for plan year 2014, but to be very specific around the timing with which you were going to bring back your recommendations. For the simple reason that you cannot, I would disagree with the fact if you imposed on the freestanding dental plans in June of 2014 a 3-month period by which they would then have to get everything ready to become even minimally certified by the open enrollment period in October. I think that's a problem, and that's only what CMS does when they tell you in August what they're gonna count for 2012.
Sure.
So, which is already passed. So from my perspective, I'm good with this, as long as you put a line in the sand and say, you'll bring it back by this meeting and decide on it, so it's at least dealt with, so you can give notice. And if you determine at that point, you're gonna do a phase-in of, you're gonna do a phase-in of credentialing and then UM, et cetera, because it's critical to put UM in there because it's a cost plan, and there are predeterminations and decisions that are made in dental every day. And there are processes that are performed, and so if they're gonna be certified, it needs to be oversight for consumer protection. The same way that the health plans who do medical have to submit everything all the time. So I just concerned that you're gonna get all the way down the pike and say, whoops, here's what you guys have to do, and there's no time to do it.
Sure.
I've been there.
Any other further comments? All right, do we have a motion to approve then the amendments that were made to item number 32?
So moved, Roberts.
All right, thank you, Dr. Roberts. Is there a second?
I would just amend that to be able to say that by the fourth quarter of this year, you come back with a preliminary plan to phase in a certification process. Is that fair? Dr. Roberts?
I think the fourth quarter is a little soon. I would say I would amend that by 6 months, give them another 2 quarters.
No, just to talk.
I agree with having that plans have to have an adequate lead-in so that they can prepare for these various, the certification of various processes. And I think that, I'm wondering whether the fourth quarter is for the agency to have, or the exchange to have that information ready for them.
No, I just want to bring it back for somebody to talk about it.
So, for the record, John Hager, so we will, we'll get with the carriers that provide the standalone dental products, that by the fourth quarter, we will have products that will be, will be in the process of being sold. So we will get with the standalone dental products, and we'll get with the national accreditation agencies to see what conversation has evolved at that point, and we can bring something back to the board in the fourth quarter. We may not bring back a final product or a final recommendation, but we'll start that process.
Yeah, you
in
can
the
choose to
fourth quarter.
table it, but at least you calendared it to deal with it. So that would be my amendment.
Staff can get the process moving at that point.
Dr. Roberts, do you accept that amendment?
Yes, I do.
All right. All right, and then you will second it?
I will second it, yes.
All right, thank you. All right, all those in favor of the motion?
Aye.
Aye.
Any opposed? Thank you very much. And the last one, page 18, is item number 35.
Yes, Damon Haycock again for the record. This standard and citation deals with non-renewal and decertification of QHPs. We discussed at the last meeting in January that regarding whether the termination notice for dental plans should be greater than the 6 months due to concerns that the lack of standalone dental plans would require carriers to offer pediatric dental coverage. However, it is believed that there will be sufficient dental plan participation from our discussions so far with carriers, and that the dental industry should conform to the same notice and withdrawal requirements of the rest of the market that is provided in NRS 689A.630. That will also include, prior to that 6-month notification to the exchange, a 30-day notification to the Division of Insurance. 60? Is it 60? Correction, 60 days.
Okay, do we have any questions, comments on this agenda item?
Move that the amendment be accepted as presented.
Okay. Do we have a second?
Second.
Okay, we have a motion and a second to accept the recommendations in item number 35. All those in favor of the motion?
Aye.
Aye.
Any opposed? All right, thank you very much.
Before we move off of that one, I know we just had a motion and voted on it. So, just to clarify, Mr. Shippey, so the carrier is supposed to let the commissioner know 60 days prior to 180 days, and let the consumers know 180 days prior to the end of the plan year, or the beginning of the next plan year?
The issuer has to notify the insurance commissioner 60 days before sending the 180-day notice out to policyholders. So it's about an eight-month process.
So, sorry for getting us going one direction. So, our recommendation, it might not be written correctly here. Our recommendation is that that the products offered on the exchange comply with the same requirements of that are the same requirements as the state requires, the DOI requires.
And the state requirements are broader than what was released in the federal rules last week.
And what was the federal rule?
I think it was 90 for obsolescence. It was a 90-day notice for obsolescence rather than 180.
So our recommendation that the notice would be the same, well, and in fact, even if we require no more than 6 months, if there is a state statute that requires 8 months, the carrier has to comply with that anyway, so.
Why don't we do this, if it's all right with the two members that made the motion, maybe we could have a motion to vacate that?
Yeah, I'd like to vacate the recommendation from item 35.
And Dr. Roberts, I think you made the initial motion. So-
No, I didn't.
Second.
Oh, I'm sorry,
I
I'm
didn't.
sorry, got a mixed
So
up here.
I'm good with vacating it as well, as the second.
Okay.
And everybody agreed to vacate, right, so.
So we need to call for a vote on that, though. All those in favor?
Aye.
Aye.
Any
So
opposed? Thank you.
Madam Chairman, I'd like to relook at item 35 and say that the minimum notification period to the exchange should meet the expectations that law or policies of the Division of Insurance.
Is there a second?
Second.
All right, thank you. All right, I'll call for that vote again. All those in favor of the new motion?
Aye.
Aye.
Any opposed? All right, motion carries. Let's go back to pages 4 through 13. And with the exception of item number 23, which we have asked the executive director to bring back for further discussion, we need a motion to approve those items.
But before we do, could we simply include 23 in that, and that the definition of sufficient, we will review the definitions of sufficient with the network adequacy requirements that we bring back at the next meeting?
I'm good with that.
Okay. All right, is everyone okay with that in Las Vegas as well? Okay, then I need a motion to accept all the recommendations, pages 4 through 13.
So moved with the amendment by Mr. Hager, with the discussion by Mr. Hager.
Is there a second?
Second.
Okay, Dr. Ahern. All those in favor of the motion?
Aye.
Aye.
Any opposed? Okay, motion carries.
Madam Chair,
Yes.
before we move off of agenda item 4, and I hope I'm not opening Pandora's box, but one of the conversations we had last month was when we were talking about the standard, we were talking about the pediatric vision, which will be incorporated into QHP. And the QHPs was whether the deductibles would be would now since they were part of a QHP, that because medical deductibles are typically fairly high, a lot of pediatric vision that we intend to cover won't be covered because a person will have to have met a fairly high medical deductible before their vision plan ever kicks in. So the question would be whether this committee or the board would want to create, say something, I'm not quite sure what, that certain primary vision care is covered independent of medical deductibles that are also incorporated to QHP.
Okay.
Was that clear there? Or is that-
Dr. Klein, I think that Mr. Hager is saying that if we look at page 19, this might be the start of that discussion.
It's a planning line issue anyway.
So if we could have Mr. Haycock, Mr. Haycock include, or continue with the report on page 19.
Is that part of it? Okay, great.
Again, David Haycock for the record. Yeah, this last issue wasn't in the table because it was something that we've been going back and forth on there with staff at the exchange and in conversations with others throughout. The issue of embedded dental versus dental riders, which depending on how this committee wants to discuss it may also include vision for adults. But Mr. Hager does not want to include that. So
Well, we'll when he's finished, we'll talk about how it can't apply to the vision.
okay. Correct, because it's QHP. One, like the report says, one concern that we have is that the pediatric dental, if it is embedded in a medical QHP, today that dental coverage is often provided as a rider, separate from the medical plan. Dental plans typically have separate lower deductibles, often $100 or less. Co-insurance and a maximum benefit, I think right now between $1,000 and $2,000 a year. So we've already started discussing this process here today. The Affordable Care Act prohibits the application of that maximum benefit, and dental plans will have to be reconfigured utilizing a maximum out-of-pocket. So, however, it is likely that the deductible will remain low, is what we assume. Silver plans are expected to have a deductible that is approximately $2,000 for an individual right now. So if that dental plan is embedded in that medical plan, a healthy family that rarely sees a doctor for non-preventative type services may find that none of their fillings and caps are paid for because they have not yet met that $2,000 deductible. This may result in families delaying necessary dental work for their children. On the other hand, plans that include the embedded dental must utilize a combined out-of-pocket maximum, which we discussed earlier today was $6,250 currently, limiting their liability should they incur additional medical expenses. So another concern that the exchange is ability to provide true apples-to-apples comparisons of QHPs that include embedded dental compared to a QHP that does not include dental because of the structure of those two plans. For the products offered on the exchange, every essential benefit is included nearly identically in every plan. So while there may be some cost-sharing differentiation between plans, it is likely that standards emerge through market selection. So, however, the pediatric dental benefit may have larger disparities when comparing an embedded dental product to a dental rider or standalone dental product. So one way to eliminate this concern is to require that any carrier wishing to provide pediatric dental must provide it as an optional rider. However, at least one carrier has been pursuing the embedded dental approach because it is thought that premium could be reduced due to lower expected dental utilization or cost sharing. On the other hand, the exchange could choose to allow consumer selection to push the market toward the optimized solution. So, due to the recent research that we've performed at the exchange, currently of the 17 declared state-based exchanges, 8 of them have decided to require that QHP separate the pricing for embedded dental plans to allow for more transparent comparison shopping. Of the remaining 9, 7 have not publicly announced their intentions, and the remaining 2 are undecided or have assigned the issue to subcommittees for further discussion and recommendation. Much like Mr. Hager has said before, we are all still moving forward. However, we're kind of late to the party on standalone dental plans.
As a nation.
As a nation.
Yeah, not just us.
And so, yeah, we're not, so we're actually, I think we're actually ahead of at least 9 other state-based exchanges. So if, Mr. Hager, if you want to add anything else to this.
Yeah, for the record, John Hager, so this does not apply to the pediatric vision benefit. As we said before, the Affordable Care Act does not allow for an exclusion or an allowance for pediatric vision to be separate. Therefore, it's required to be an essential health benefit and required to be embedded in the same deductibles, coinsurance, copays that the rest of the plan have. On the dental side, if the dental is embedded in the plan, then it's required to abide by the same cost-sharing structure as the rest of the.
So can I correct you?
Please.
I'm only going to correct you that it has to apply to the maximum out of pocket.
Correct.
The health plan decides
Whether it's a copay or
whether or
coinsurance,
not,
yeah.
the health plan
Okay.
decides which benefits and which cost sharing specifically applies to that product. You
Okay.
know, unless you guys determine that this is the maximum allowable that you're going to allow for that. And kind of from my perspective, whatever reasonableness calculator you would be imposing upon the standalone plans needs to be a reasonableness that is being put on the embedded pediatric dental, right? Because the whole thing, when you look at the plan, it really is to try to have kids taken care of. And so, I could argue from your side that you might wanna keep the cost low, so you could arbitrarily decide or have the Division of Insurance say, here's the maximum deductible you can have for dental, you know, or whatever, in order to make sure the services are available. So, I mean, however you chose to do it. It's highly unlikely that I think we would embed dental, since we don't run a dental network, but some of the big boys do, and it's very profitable for them. And so, you know, it's just a question, if you do it as a rider, then it's a lot easier to make it side by side.
Thank you for the correction.
No, it's
Absolutely.
important. I only
Yes.
corrected you because it's important to just not to assume that that $2,000 would automatically apply.
Thank you. Like we said, we were looking at this all the way up until today. Still are trying to figure this out. So that we're all clear, when it talks about a reasonable cost sharing, then is it saying that the exchange will only set reasonable out-of-pocket maximums, or should we be setting the a reasonable deductible as well? Or not should we, could we, or should we?
I'm just,
I mean, I don't know.
you know, some exchanges, I thought, basically told you what plans you had to offer with what deductibles, you know, on the medical side as well. So I think you have a broad-based issue. The question that I would have, and it's not that I want to mandate anything, but you want to make sure that services are available. So if you had a parameter, you could set a parameter that would say no more than X of the big deductible would be counted towards dental. If you want, rather than set a dollar amount, then proportionally maybe it would work that way. You know, because none of the preventive, I'm gonna make the assumption that, and I don't know if this is the intent, that since preventative care has to be covered, it's very explicit about what's preventive, that the preventive services would have to be covered with no cost share, right?
Correct.
Okay, right? On the dental side, the same way they are on the medical side. It's just a question for you about which way you want to move to try to make sure that you have access. Because, I mean, what concerns me about not paying for it, and I know it's expensive, is that now, coming across my desk, I very often see children that have literally a cavity in every tooth that has to be taken to the hospital to do restoration because no one's cared for those teeth. So on the medical side, we're paying thousands of dollars for the facility and the anesthesia because no one's dealt with the child, you know, early on to fix that. So there is a positive to getting it addressed early by making it more affordable.
For the record, John Hager, so I think, so again, thank you for the clarification. So disregard the issues about the deductible and not getting any service that the carriers could set separate deductibles, separate co-pays for various services. So that still leaves us with trying to show on the exchange an apples to apples comparison of products that are embedded versus products that don't have QHP. So for example, if you embed a QHP in a medical plan, there will be, theoretically, if you're adding a if there's a dental service compared to a plan that does not have dental, theoretically that plan should be more expensive than the medical plan by itself. So when you go onto our initial screen to choose a medical plan, people will automatically be drawn toward the cheaper plan without dental coverage. Then they would go next to the dental page to select a dental plan, and they'd have to either select or not select a dental plan. Now, many states, from what we've seen, are not requiring that children purchase or that families purchase for the children dental coverage. If you require it, then it as part of the QHP, whether it's embedded or if you require a purchase going forward, then theoretically that would lower the cost of premiums because everybody is required to purchase it. As soon as you have an option to select something, then people that feel they don't need it won't select it, and you have adverse selection issues there. Although I'm not sure if we can require purchase unless it is embedded.
So I understand the final rule also provides that adults don't have to purchase it.
Correct.
That's correct.
Right.
So yes,
And John, when do you need, I mean, we need a decision on this like a month ago, right?
This is Dr. Klein. Can I make a suggestion, please? We've come across these kinds of issues many times on the board and in committees, and the prevailing wisdom seems to be, and I'm beginning to agree with it, that rather than creating complexity, given there's so many things that we don't know how they're going to work and time is running out, that we choose simpler solutions that may not be perfect, but get us there quickly, and let us move forward and come back and revisit those things in a year or two. And to me, it just seems like a dental rider is a better choice for a couple of different reasons. First, because it makes a comparison between dental plans easier. Second, it makes a comparison between medical plans easier. And third, because rather than trying to figure out a complicated formula with percentage of copay out of a medical plan that can go to dental costs, you have a separate plan with separate issues that people can compare directly. So I think that the advantages of having a dental rider outweigh the disadvantages, and so I don't know if it's appropriate to make a motion, but I would move, if it is, I would move that we elect to go with dental riders as opposed to embedded plans.
For the record, this is Wayne Finch. I would like to ask a question to the committee itself.
Okay.
As to, can you provide a definition for what you mean by a rider? All right, riders in the industry have different meanings. I would just like for everybody to be able to agree upon what a rider is. No, standalone plan. A standalone plan is a product where there's a certificate that can be sold on its own, regardless of medical going with it. A rider typically depends upon the existence of a medical certificate upon which the rider is attached. Does everybody agree with that?
So in a sense, this isn't a rider because you can't purchase it's not a standalone plan because you can't purchase a standalone plan unless you purchase a QHP.
Right, a rider cannot be purchased on a standalone basis.
So it's,
A rider has to be purchased along.
So what's the correct insurance company term for additional coverage that can only be purchased if you have primary coverage?
A rider.
A rider.
Because it's already this,
Right, I just wanted to make sure as
opposed
opposed
to
to
standalone.
standalone. Right, there is a difference between standalone and rider.
Okay.
Right. Now,
So bringing that up, could I ask a question, perhaps of Glenn, if Mr. Shippey, if he can? Currently, I believe if the rule says that if a dental plan is embedded with a medical plan, it's required to follow the same actuarial value metal tiers, 60, 70, 80, 90%, as the medical plan. But a standalone plan can follow the high-low actuarial values of 85 or 70%. So if a rider is offered, it is offered contingent on selecting the QHP to begin with, but can it be split out so that it is offered at an actuarial value that is similar to the standalone product?
I'd have to think about that. I can't give you an answer today, sorry.
I thought the actuarial value of the plan had to be an aggregate of 100% of the benefits, provided that the EHBs that were embedded in the plan met the definition of the essential health benefit that was assigned. So for the sake of argument, if the dental costs, a part of the plan, represent 8% of the plan, the dental could be enhanced or taken away, as long as it met the needs, the cost sharing there. Not necessarily, you could be a 90% payout, whatever you decided that it needed to be, right, with the out-of-pocket, based on how people were gonna use the benefits in aggregate. That's what I would say. So, I mean, I know you're the insurance guy, but, so it doesn't mean that if it was a silver plan, that the dental thing had to be 70%.
Correct.
That's what, right.
Right, in aggregate, the entire set of benefits has
Correct.
to meet 60, 70, 80, or 90.
Right. But you couldn't impose either the low or the high in that thing, because it has to meet the metal.
And so is the definition of embedded, does that include when a carrier offers dental as a rider?
Well, and what I would
Yeah.
want to know is the rider, is it specifically addressing the pediatric dental component? Just that, so we're not talking full-blown dental coverage for the family, it's just that one element. Instead of being embedded, we're stepping back and saying it's a rider now, subject to the metal tiers, purchase of a QHP, but it's only how we're structuring it that we're discussing that.
So comparison when you're shopping,
Right.
you know what you're getting.
So you can look at the
for.
standalone Delta Dental, pediatric dental, and what it provides and what its cost is, as opposed to what
The
carrier
rider.
A or B rider will have and their cost.
Or,
Did we agree that we were going, I thought we agreed though that we were going to have standalone, now you make me think about my words, that we were going to have, adult dental riders in the plan as well. Did we talk about that as well?
That's above beyond the pediatric though.
Correct, so I mean, so I think we're not just talking about, if
I'm
we
guessing
settle the
they
issue of
want
riders
to
versus
both,
embedded, then we're gonna have multiple
to
different
spread the
riders.
risk and make everybody buy it. It would be, the prudent thing is if they embedded both, pediatric and, because they only have, because they can put cost sharing on the adult, you know, and max benefits.
How can they separate out the pricing then? And how are
So-
all these
Yeah,
other states
it's not a
So,
question
mandating?
except-
wait, so we're, let's make sure we got one conversation going on.
Yeah, because we've got a motion on the floor right now, and some discussion going in between it.
So if you chose to proceed with the motion, oh, we should second it. I'll second it so we can talk about it. Okay, great. Doesn't it have to be seconded before you
Yes.
talk about it? Okay, good.
Yeah.
Now, my motion,
Robert's rules of order, right? So,
Yes, Dr. Klein, that was your motion.
alright,
so,
which is 15 minutes ago, so I just wanted to.
so, is it reasonable to restrict the carrier's ability to meet the letter of the law because you want to potentially favor the consumer's ability to make a more informed choice?
And
I mean, to me, because that, to
that's
me,
the question.
that's the balance that you have to achieve.
But this, for the record, this is Wayne Finch. Going down the road of the rider, Mr. Hager, how would the vendor propose splitting the cost between the medical QHP and the pediatric dental rider and presenting that to the customer on the exchange?
So the first selection that an individual makes is for the medical QHP. Whether it's embedded or not, however we decide to do that. Part of the concern is if it's embedded, the individual will immediately try to go toward the cheapest plan, which may end up meaning that the plans that have it embedded go away altogether. On the other hand, they go to the next page and it says, here are your options for dental. Now, if dental was embedded, then you wouldn't go to that page because you would have already had it, it's already covered. But if you chose a plan that does not have dental, you go to the next page and you would see either the rider that was attached to that plan, if that plan offered a rider, or a standalone dental plan, and make your selection at that point.
And the
Please.
rider cost would only be required to be purchased by any child dependent, correct? You would only be able to choose the rider or the standalone pediatric dental for the children, correct?
My understanding is that it's not required, or the federal rule does not require purchase of the rider or the standalone dental plan, that it has to be offered, but it does not have to be purchased.
It's just pediatric vision that has to be.
Really?
No, vision is part of the medical. Yeah, so it says, the rule on page 78, thus in an exchange, someone with or without, with a child or without, can purchase a QHP that does not cover the pediatric dental EHB without purchasing a standalone dental plan. Can we ask Delta?
So I would, to answer Dr. Ash Jackson's question, I think it's okay to limit the ability of a plan to do business in the way it wants if we're enhancing consumer information. I think we have truth in lending laws. I think we have documents on water heaters that tell us how much it's going to cost per year. We have all kinds of things that are there, that our society's put in place to allow a consumer to make a more educated choice. And I think that's completely fine to favor consumer education in terms of, that is one thing we should be doing. So I would, to answer your question directly, the answer is yes.
Thank you.
It's my perception of that.
We have intermittent public comment.
I've asked the representative from Delta Dental to come up to maybe perhaps help us answer some of these questions. Do you know the answer to the question about the rider and whether that can be offered at the high-low values versus the 60, 70, 80, 90 values?
I don't in particular know. I imagine that a state has pretty great flexibility to set this up as they desire. But I agree with the earlier point you made, John, about the difficulty if a QHP who embeds the dental has to meet the 4 metal tiers. And that's with the dental being calculated as part of that actuarial value. When you split that out, that will presumably have some effect on that actuarial value, either up or down. I would assume down, because it's less benefits, but depending on what metal level it is at. I don't know if it's a great enough effect to drop that otherwise qualified health plan out of that metal level. So say at silver, you have a de minimis plus or minus 2%. If you go in at 68% with an embedded dental rider, and that is part of that calculation to get to 68, and then you remove that dental rider, maybe it drops to 67, and then you're no longer considered a silver plan. Those will be calculations I imagine would have to
Dental benefit,
be.
not dental rider.
The benefit.
Well, we're still not sure about how the rider affects.
Exactly, yeah.
So this is Glenn Shippey from the division. So it's not the value of the benefit. Again, you could have the cost share built into dental that is at that actuarial value. So for a silver plan, at 70% for that dental piece, so whether it's in or out, it's not going to move the total actuarial value for the product. So subtracting a benefit doesn't move the actuarial value. Changing a cost-sharing structure is what changes an actuarial value. So if the cost-sharing structure in the dental benefit within that medical plan were very different, it could swing it if it was right on the edge. It's possible.
Right.
Or, I'm gonna push back at you, or if there was an assumption of utilization of X amount of the dollars associated with that dental plan, all right? And then that comes out, that also will move it.
Yeah, those are the old days,
Right.
induced utilization and all that. That's not what's going to move actuarial value.
Yeah.
That would be the pricing actuarial
Yeah, that's
value
right.
in the old days.
Okay,
Federal AV is independent of that,
Okay.
so.
So what is the
So
pleasure?
this is, for the record, this is one thing. So what I'm hearing then, Mr. Shippey, what you're saying then is that the inclusion or exclusion of either the pediatric dental, whether as a rider or as a standalone benefit, would have no impact on the actuarial value of the medical QHP.
No, that's not what I said. It could. It depends on the cost-sharing structure within the dental benefit itself, right? So if the cost-sharing structure within a dental benefit is similar to on an actuarial value basis, similar to the cost-sharing structure of the medical plan, then whether it's in or out won't have a significant impact.
So Mr. Shippey, so if there's a, say, silver plan, typically we think will have about a $2,000 deductible, at least that's what the actuary reports say. So a medical $2,000 deductible for medical, and the dental plan has more typical what's today a $100 deductible. You pull out the dental benefit, that creates a leaner plan. So that could reduce the actuarial value.
If it was on the edge.
It was on the edge, right.
Right, it'd have to be on the edge. I think it's pretty small, but
Yeah,
it would have to be on the
Okay.
edge. Yeah.
So can I ask a question? So if what I'm hearing is the purpose of whether to embed or offer as a rider to the carriers, the value of offering as a rider would enable those childless adults who do not have a need for pediatric dental, they wouldn't have to pick it up. So the cost to them would be conceivably lower. So there's flexibility there, as opposed to a carrier who would embed it, whether you have a child or not, you're paying for it. The other thing with the rider that I'm hearing is you want to be able to capture a line item cost for comparison purposes on the exchange. So therein serving a consumer interest to see what the standalone pediatric dental cost versus what your QHP rider will cost. So that's kind of where we're at on this, and that's the purpose of considering the rider.
Right.
Okay, because the ACA says you don't have to purchase pediatric dental. It only has to be offered to you, whether it's, through the carrier or on the standalone side or what have you, correct?
Inside.
Okay.
Inside.
And outside, the rules have become even more confusing. They've answered a little bit, but so part of the difficulty we had is going from outside to inside and vice versa. The plans that are offered, the QHPs that are offered outside the exchange have to be priced the same. If you are off the exchange, the way the rule works is if a carrier is reasonably assured that the individual has purchased a standalone dental product, they don't have to offer the dental product off the exchange. If they haven't purchased a standalone dental product, the carrier has to offer the dental product off the exchange, but it doesn't necessarily say that they have to purchase it, although there's some kind of there's a couple places where it says purchase, but then there's a place that says that it doesn't have to be purchased, and that's
That's just your assured coverage.
yeah. So there's a place where it says basically that it has to be offered, but it doesn't necessarily say it has to be. It just says offered, it doesn't say purchased. So we think, and again, the DOI will have to review this, I think, some more, that if you offer it as a rider, it's offered, it doesn't appear to have to be purchased, so that way you have the same on and off the exchange either way, so the carriers pretty much all will have to create a rider of some type if they're going to offer it off the exchange. Now, if they don't offer it off the exchange, it's a separate issue. They can offer coverage on the exchange without dental as long as we have the pediatric or the standalone dental products. But if they are offering that QHP off the exchange, they're going to have either dental embedded or a rider.
I can tell you that was our assumption, that we were going to have to proceed in that direction.
And so the question then will be whether or not the exchange requires it to be offered separately as a rider. Now, this last paragraph that we have on page 19 talks about the other states requiring it be priced separately, but they didn't necessarily say it's priced as an optional rider.
Correct.
So, don't know what the right answer is.
Well, I think given time, we'll know. And I would request that we move the question at this point, because I don't know that we can answer many more of these questions until we get a little bit further along in the process.
Well, the concern that I have is that people are doing plan design and development right now. We just signing actuarial agreements for hundreds of thousands of dollars to try to figure out where we're going. And I think that to not have some direction to give to the board as a recommendation, I think would be problematic.
So to restate what I said, would it not be simpler just to have a rider?
Well,
Move forward?
I would ask you if we could amend that to be able to say that offered to be priced separately, because then that gives the board some flexibility to do some more research on whether or not you want to call it a rider or not.
Sure, so price, I'll ask my insurance consultant here, so, an embedded plan, but if priced separately, does that?
Puts you in the same.
It's a rider.
Same
Okay,
price.
yeah, I'm fine.
Same thing.
I think this is Steve Woodley for the record, I think the carriers would like to preserve all of the flexibility that they're entitled to and certainly not undermine the options available to the consumers. So if we were to make a motion as to proceed on this, I would say either the carriers have the existing option, which is to embed the pediatric dental into the QHP, subject to all of the ACA requirements for a maximum out of pocket and plan design structure. Or the exchange provides flexibility to say if that solution doesn't work, that a rider is available to be priced appropriately, consistently, and that could be used in and out of the exchange, again, for efficiency purposes.
To meet the demands
To
of
meet
the
the,
EHB.
exactly, to meet the demands and requirements of the EHB. That way, you've got efficiency, you've got flexibility, doesn't take anything away from the carriers, and I think you'll get your pricing transparency out of it as well. Because from my perspective, just as a consumer, I can't imagine why you would want to embed the benefit into one of the QHPs, because it drives the cost up. If you don't put the dental coverage subject to a deductible, it's a copay, and they have $4,000 of dental work, that can be paid out. So having it as a rider, again, addresses childless adults, it provides for pricing transparency, it works in and out of the exchange. So I think in that respect and in that framework, it serves multiple purposes.
Well, and I
So-
think that's what the motion is.
So
Okay.
Well, no, I don't think so. I think that
Steve, what this was doing.
I think the
Yeah,
motion
I don't
is
think
just
my motion was for a rider, but I guess my question would be, and you know, you mentioned the issue of $4,000 medical deductible, and I 100% agree with Dr. Ash Jackson, who said that we're not doing primary care for children right now, and we are all paying greater costs down the road to remedy that. And the only thing is that the insurance company that denies the primary care, you know, this year, hopes that it won't be the insurance company 10 years from now when we have to do the dental restorations under general anesthesia. So I guess my only point here, you know, I'm pretty transparent. I want to do the right thing for kids. And so I want to make sure that kids get their dental care, that we don't have a situation where basic dental care is part of a medical deductible, and so the kids don't get the care. So whatever happens, to get my vote, I have to be assured that whatever the carriers do, somehow preventive dental care is carved out for those kids as part of the policies, so that they're getting that. So it's not like somebody says, well, I'm not taking my kid to the dentist because I haven't met my $4,000 deductible this year yet. That can't happen.
Well, Dr. Roberts, I'd like to respond to that for the record. I want to disabuse you of the notion that decisions about taking your child to the dentist are based on purely financial. And I can say that because in the Medicaid population, they have no copays, they have no deductibles, they have absolutely no financial disincentives, and yet, more than not, most of the time, if they do take their child to the dentist, they have multitudinous caries and difficulties. And it's not from a financial disincentive. So people make choices about whether they're going to take their child for preventive dental care on other issues.
But certainly financial is a part of that. And if I understand, not to get too far deep into the weeds, but if I understand correctly, Medicaid does not pay for filling caries, it only pays for extractions. Do I know that correctly?
No.
That's incorrect. No,
Not for straight med.
That's for
Children and for,
it pays for adult, pays for extractions, but not for filling cavities. That's correct. Okay, that was my understanding.
So
So
there's two issues.
So for the
rider
record-
issue and the cost share issue. and
Yeah.
they're mixed up.
So for the record, preventive dental services are 100%, have to be 100% paid for by the plan. That's required by the ACA. So your cleanings, prophylaxis, those kind of items are 100% paid for by the plan. The the things like cavities and caps and things that are not considered preventive would be covered by the dental plan. And I think we discussed earlier that they can have separate deductibles. So the information that's in this report is incorrect regarding the deductibles. The plans can have a lower deductible for dental benefits, different cost sharing for dental benefits than for the medical benefits. It was the out-of-pocket maximum that was combined. So that's a separate issue. Now, whether or not the plans choose to have a lower deductible for dental is another question. Mr. Shippey?
There is an area of emphasis when we're reviewing the benefit design, and that is discriminatory benefit design. So this kind of fits into that as well. Now, we're going to have to, as a regulatory agency, we're going to have to identify what we consider unfairly discriminatory benefit designs, and if there's a deductible for dental that is unreasonably high, that's something that we should identify and go back to the carrier with and work with that carrier to address. So it's not as if it's going to be a free-for-all by the industry, that they're completely free to decide, what cost share they're going to put on a specific benefit like dental. We still are, under the ACA, we still must make those determinations as a regulatory agency.
Would it be appropriate for either this committee or the board to suggest to DOI that it look at dental out-of-pocket and dental deductibles and co-insurance and to make sure they're not, whatever the appropriate verbiage is to sort of emphasize that point, or is that not necessary?
Dr. Klein, I think that's in one of these sections. I can't remember. There's a discriminatory benefit design section in here somewhere. I can't remember where it is.
Right, that's part of
so that should cover that piece.
And so what I'm hearing is to have the same deductible for dental as for medical is discriminatory.
No.
Seems the opposite to me, but I'm happy. That's what you're saying. What I'm hearing you say is that if you had the same deductible for medical benefits as you did for dental, that would be a discriminatory plan design. It almost seems like to me that would be the opposite. Unless I'm missing something.
That's some background music. So
Yeah.
the discriminatory test, and we're waiting for further guidance from HHS, but whether that cost share for that benefit is designed to discourage certain individuals from utilization.
Right.
So it's not so if what's out in the marketplace, and the dental marketplace is at a level that's much lower than what's being proposed to us by a medical insurer, then that would kind of be red flag, and we'd be concerned about that. So we're going to have to, we have to figure this out, and we will get some guidance from HHS on this down the road soon.
Can you guys down south hear Mr. Shippey over the music?
Yes. We're sort of enjoying the music.
I think it kind of quiets down when we talk, so I think we'll be okay.
So John, Steve Woodley for the record, so can we just clarify from a perspective of going forward with how the carriers can start building plans, what is the structure that you would envision? Do you want to make it as a rider as to how this would be offered, or do you want to allow the flexibility to have it embedded in addition to a rider? I mean, that's kind of what I think Linda Ash Jackson was asking. I'm kind of following in on that as we build product.
Right. So we're just trying to understand, and if in fact, if you say that's what you want to do it, then you can also specify that you want the pricing for that particular portion of the embedded plan broken out separately for people to see what they're actually paying for, right? So, I mean, that's the other reason.
Right, so certainly breaking out the pricing will definitely help, and I think if we do anything, we at least need to break out the pricing for the dental piece so that there can at least be some comparison to the other plans. I don't know if it's still apples to apples when you've broken it out. If I could ask, please.
Well, a couple of comments. Just on the one we're on, the standalone dental industry is fine with as much flexibility for the qualified health plans. They can embed and they can offer a product without the pediatric dental. That's the main focus is that, and separate pricing doesn't automatically mean that it's a separate offer. So I would just want to make sure that we clarify or speak to it. If you by extension you're saying the separate pricing means that they have the option to say, okay, I will take that with this plan, or I won't, and I'm going to go shop for a standalone plan. Because if you leave that flexibility just to the qualified health plans, then you're leaving that flexibility to mean all of them just embed. So that would be one point. The other point would be on the preventive care. Standalone dental products are not held to 100% coinsurance on preventive. The analysis goes to a study or a governmental that lists all the procedures that are considered preventive. Almost all of them are medical, and the only dental components are actually done in a pediatrician's office. It's referral to a dental home, making sure that there's fluoride in the water, and if not, provide a fluoride rinse. So that is not anything that's covered under a standalone dental.
You're talking about U.S. preventative A&D.
Probably, yes. I didn't know to remember it. Now, that's not to say that universally most dental plans offer preventive care at 100% today. And the industry would want to stick to that. The only thing that might interfere with that is if the deductibles or the out-of-pocket maximums are arrived at a reasonable limit by the Department of Insurance, for instance, is high, then you have to use other levers in your product to get to 70 or 85. And some of that could be, well, then we're going to, if we're stuck with this deductible, then we have to lower 100% preventive to 90% in order to meet. So, look, as I said, the industry wants to provide 100% for preventive, but they don't have to under the guidance issued by the federal government. So I just wanted to clarify that.
Thank you. If you're on the phone and you want to put us on hold, please just hang up and redial later. That when you put us on hold, we have to listen to music. But thank you for picking up again.
I'm tired. No, I mean, seriously, I live this and it's confusing, so.
And I agree. I agree with the perspective of the dental consultant, the Delta Dental. It's a mandated offer. That's exactly what it is. If it's embedded, it's already in there. They take it, whether they have children or not. If it's offered as a rider, whether it's inside or outside the exchange, it's a mandated offer. They can either pick it up or not pick it up. And so I agree.
Okay.
Yeah. That's my understanding.
The motion is for a rider, so if we vote that down, then Steve has to make a motion, or amend the.
I just don't want to take away the carrier's opportunity. If they want to embed for any reason, that's the only thing I'm saying. If we mandate that this is how it's going to be, that's fine, but then,
So your recommendation would be price it separately, so we can see the difference in price.
Let me amend my motion. Let me amend my motion and see if I captured it. And that would be that we offer riders and or embedded dental plans within the exchange, but that if they are embedded plans, the pricing for the dental component must be broken out separately.
Yeah.
Is that accurate?
This is Dan Hayrock for the record. The way I envision someone buying insurance on the exchange is they'll select their qualified health plan, and if it's an embedded dental plan, even if you see it and don't like it compared to a standalone, you can't get rid of it, or you got to back out and start all over again.
Yeah.
And I don't know how many people are going to take the 1 to 2 hours selecting all of their pricing and their plan benefits and pick their carriers and find their doctors, and then hit that last page to select to not select dental, but to see this is the dental that you get. And then, oh, by the way, here's this other really nice dental plan you could have had you not gone there to begin with. And so I don't know if that's the message we want to put on the exchange's web portal.
Yeah.
So you're arguing now for riders without embedded plans.
What we're saying is we want to make sure you understand that
the pricing transparency,
the differences and how it works. So it's not necessarily one way or the other, but you go and you select your QHP. If you've selected embedded dental, you don't select any dental plan, and maybe you just don't even see the options. And if you select a plan that doesn't have it, then you go and select your dental, whether it's a potential rider for that plan or it's a standalone dental product.
I mean, you could always have something that flashed that said you already have dental. I guess, to me, some people are gonna want, some people like the one and done solution. I only have to deal with one company, I don't, so this has everything great, no problem. My kid needs stuff done. Some people are gonna be more price sensitive, especially if they're not subsidized, so. And some people are carrying a Delta or an Emeritus card or whatever the other ones in their handbag or wallet already and just are looking for that name again. That's just how it goes, so. It's just as confusing, I think, when people go online and try to buy the Medicare, when, they say, do you want a Med Advantage plan or do you want a PDP? And they select the Med Advantage and the PDP, and then they get a letter 2 months later saying you can't do that. So, I don't know. I hate to take away people's flexibility to embed a product. But if they embed it and they price it as an add-on for the rider, isn't that the same thing?
Well, the only thing it's gonna be confusing is if it's an embedded product, to Damon's point, you can show the line item cost or what the portion of that total premium is that's allocated to dental. But at the end of the day, if you say, well, I can go over here to Delta and pull the pediatric dental on my own, well, you've just basically, given up that QHP plan is what it's doing. So to Damon's point, I don't know that it would serve any useful purpose if it's an embedded pediatric dental into the QHP, then maybe the pricing transparency serves no purpose. It causes more confusion. So then it goes back to a rider. So for carriers who want to offer the pediatric dental embedded, it's just, the price is the price. The premium is the total QHP premium. And then for the carriers that want to offer it as riders in and outside the exchange, then you actually have the line item cost that can then be compared to the standalone, Delta pediatric dental.
So you just let
Let
select.
me restate what I said about half an hour, 55 minutes ago, that there's an awful lot of complexity here, doing it different ways, and that we're running short of time, and we have a lot on John's plate that he's doing. So it seems to me like riders would be the simpler way to go forward, acknowledging that it takes away some flexibility from carriers, and this is something we should address again in a year or two when we have some experience and the exchange is underway. But I think if I'm understanding correctly, it's simpler if we just have riders.
Right. So I think you've restated your original motion, just simplified it, and we have a second to that already. So I'm going to go ahead and call for the vote on that then. All in favor of the motion?
Aye.
Aye.
Any opposed? All right, got it. Thank you.
I
You
just
can't
have
say we
one
didn't discuss it.
clarification, so if we're asking people to offer as a rider, my presumption is that rider pricing has to incorporate the metal tiers? And not the 70, just asking, and so I'm asking for clarification around the,
We need to come back with
With
that
the-
clarification to the board.
okay, good.
So the clarification, so the recommendation, if I'm clear from the committee, is that if dental is provided, that it be provided only as a rider, so that we can do apples to apples pricing comparison between riders and standalone dental products. But that we need to come back, and this was separate from the motion, but we do need to come back to the board with a clarification on whether or not, if it is a rider, if it is supposed to comply with the 60, 70, 80, 90 metal tiers, or if it's supposed to comply with the high, low 70, 85 tiers as a standalone dental product does. And we'll work with the DOI on that one.
And it's embedded, pediatric dental is embedded into the continuance tables for the AV calculator, so it's in there.
May I, before we move past this, we talked about, I don't know if you're getting ready to pass this, but we talked about dentistry and preventive services, and I originally started out asking the question about vision and medical, deductibles for that, since they are going to be embedded in a QHP. So can somebody educate me and let me know if basic preventive vision screening is part of QHP without deductibles, 100% coverage, or if it's not? Because then, if it is, I'll leave the subject alone.
Today, it's generally provided as not pediatric, but it's generally provided with a small co-payment for the visit and a maximum payable amount for frames. And if you go to the network, you get frames up to thus and such amount. So many lens from a participating provider, lenses every year, exam every year, and frames every other year. That's generally the benefit.
Is that a vision rider, or is that?
That's a standard vision rider. I can tell you that, as I said before, today I met with and I guess I left it on my desk, today I met with the vision people, and they have the ability to quote a pediatric vision that is 100% for the exam, 100% for the glasses from a specific set of glasses that meet the definition at least of an out-of-state Medicaid plan, and lenses, et cetera, for a very reasonable amount of money. So there would be no out-of-pocket unless people chose to have add-ons.
So my concern, and if I'm incorrect, just tell me I'm incorrect, I can deal with that, is that we have vision riders with 100% coverage and frames and all of those things, and then when we embed vision into a medical QHP, then that deductible, that's $3,000 or $4,000 if you're having heart surgery or whatever, now gets incorporated into the vision, and so now it's, I can't buy glasses because I've met my $4,000 deductible. Same argument as the dentist, as the dental thing, almost reiterated. So that how do we protect, how do we carve out, protect, whatever it is you want to say, an embedded vision plan within a QHP so that preventive services and basic kind of services are still provided before you met that $4,000 deductible or whatever it is?
Dr. Klein.
The high departments, for the record, I think you also have to distinguish what are basic preventive vision services and basic vision screening.
Oh, that's great.
It's done by pediatricians as part of well-child examination.
Right.
So if they have a copay or whatever for that, that's all they pay.
So,
Dr. Klein,
Dr. Klein, I have the federal vision plan, the standard option in my hand. And basically, when the EHB provides for no cost share for an eye exam, no cost share for lenses, and no cost share for a frame. So,
But that's,
We're done.
well,
We're done.
Dr. Klein, I will bring,
Thank
in our report to the board, I'll bring back what is considered preventive from the CDC guidelines.
right,
Those are EHB, and even though they are in the list of EHB, it does not mean that the carriers need to comply with that cost sharing. They need to
Right.
comply with those benefits being covered.
right.
I'll bring back,
I'm sorry, I'm just, now you just threw me for a loop.
can I,
Somebody just said that all those are covered
no,
without cost sharing, and you just said they weren't.
so it was slightly misstated. Those items are covered with no cost sharing in the FedVIP plan. However, that plan defines what the benefits are. It does not it defines the essential health benefits, the services that are covered, but not the cost sharing. Remember, we had this discussion about what EHB actually are. It's the services that are required that are covered, not the cost sharing. The 100% cost sharing applies to preventive services that are outlined by the CDC, and I will bring back those services in the report to the board with this item.
And your recollection would be that would be vision screening probably, but not classes, so that would be a,
That sounds
That's
about
a
right, but
Pediatric vision screening in the pediatrician's office.
yeah, and that sounds about right, but I will bring back a definitive list from the CDC
No.
on vision and dental services that are covered at 100%.
so we're all tired, I'm not trying to beat a dead horse here.
Task force.
So I'm not trying to beat a dead horse here, I really am not, but, so right now we have a vision rider, you get screenings, and you can get a lens every year, every 2 years, whatever it turns out to be, not to exceed $400, whatever that number is. My concern is that once the vision is part of the EHP, part of the medical QHP, then that deductible gets incorporated into the larger medical deductible, and a kid may get, the optometrist may say, okay, fine, you need glasses, and the QHP says, yeah, that's right, it's part of your $4,000 deductible, as opposed to today, where if you have a vision rider, you get those glasses paid for. So my concern is that rather going forward in terms of vision, pediatric vision exclusively, we're taking a step backwards rather than a step forwards. That's my concern. Somebody tell me I'm wrong.
I know that we don't disagree with you. Mr. Shippey would like to make a comment.
I just want to make a comment that this is a market-wide issue, not just an exchange issue. Essential health benefits are market-wide, and this would fall within discriminatory benefit design, those responsibilities when we as a regulatory agency have to review, all these products, all the different cost-sharing responsibilities for each of the benefits within that design. And so it'll be, it's going to be part of the processes that we're going to have to create and hopefully identify.
I'm loving discriminatory design. Explain to me, so what you're saying, and I know you can't, speak, for something that hasn't happened yet, but when you see a medical QHP with an embedded vision plan, your expectation is, so that it doesn't have discriminatory design, that there will be one set of deductibles for medical benefits and a separate set of deductibles for vision. That's what you would envision, no pun intended, not counting, not being discriminatory design?
That's what I personally would, yes.
Okay.
That benefit wouldn't fall to the larger medical deductible.
Since this is such an enormous issue, maybe when Mr. Kipper comes to the board meeting, you can brief him on this conversation we've had today so he can address it more definitively, but I do appreciate you saying what you said. That's been very helpful.
And it is, I just want to emphasize, it is market-wide, outside the exchange.
Okay, yes. Thank you.
I need to wrap up this meeting by about 4 o'clock because I need to be back in Reno for a meeting at 4:30. But if we don't have any other discussion on this, I think we'll close agenda item number 4. We have a brief update on aligning the service areas with rating areas. That's just an update that CSIO did not approve what the Division of Insurance had requested.
Mr. Shippey?
Sure, the final rules that were just released clearly do not allow the selection or definition of rating territories that we exposed. Specifically, what we're not allowed to do under the final rules is to include Pahrump with Clark County. And that was verified in several conversations that we had directly with CSIO. So we are evaluating what our options are at this point internally, and it's a high priority of ours, and we're not, we'll have some guidance on that soon, to use federal terminology.
Okay, and then, John, do you have anything on possible dates for the next meeting?
We don't have possible dates. We need to work with the DOI to come up with recommendations for plan certification. For network adequacy. The DOI is moving forward with a bill to move network adequacy to the Division of Insurance from the Health Division, and to more broadly define network adequacy to include other products. But that process, even if it is even if the legislature were to approve it tomorrow, there still has to be a regulatory process that wouldn't be done for several months if then. So we've discussed with the DOI, it makes sense that we work with the DOI to come up with some statewide standards that the exchange could use its federal authority, the authority under the federal regulations, to apply to qualified health plans within the exchange. Carriers would obviously be put on notice that such a standard that is recommended by the DOI would likely, assuming it gets through the regulatory process, would apply to all carriers. But that would allow us to get through to 2014 with network adequacy standards. So we'll work with the DOI pretty intensely over the next couple of weeks. And sometime after the March board meeting, we'll have another meeting to bring back those network adequacy standards to this committee and bring it to the board in April. Does that sound right, Mr. Shippey?
Yes.
Right, so you'll be sending out
We will.
another calendar request then? Okay.
That would hopefully be the last committee meeting for this committee. But I'm not going to promise you anything.
All right, I'm gonna open up for public comment. Is there any public comment in Las Vegas?
Nobody
No
left.
public. I didn't know if there was somebody behind Dr. Roberts or not. Any public comment here in Carson City? How about on the telephone? All right, then we'll go ahead and adjourn the meeting today. Thank you, everyone, for your time and discussion.
But I'm glad we had a really good conversation. I don't know what the right answer is.
I don't either. I wanted to make sure people knew what we were doing.
No, I got out just for a minute. because I was supposed to be there for 1 o'clock.
Oh, yeah.
I just thought, I wasn't believe it. I guess that's happened before. Because I know you guys knew more about it, but I just thought, you know, it
Here's the,
sounded like state music.
That's what I would like.
specific product in the federal rule.
Okay.
It's a 90-day notice in the federal rules. Our state statute doesn't just.
Well, you don't, I mean,
I knew it was 180, but I thought they had